Hi everyone, good evening, and thank you so much for joining tonight. We are really delighted to be able to host this session along with John and Duncan and the CPD for Vets team. So hope you're all safe and well at home, and that we can provide an enjoyable and informative evening for you. So tonight we will discuss the staging, diagnosis and ongoing management of osteoarthritis at the distance. As we all know, pet owners are spending more and more time at home, and they're likely to notice the subtle signs around osteoarthritis in their pets. And despite the world seeming to be falling apart on every level, what we do know is that pets still get achy joints, and owners are still passionate about their dogs and cats' joint health. So whilst routine checks are currently inhibited in adherence to our CVS guidelines to reduce in-clinic footfall, it's a really opportune time for us to tonight be joined by Duncan, who is joining us from North Carolina, where he works as a professor of pain management and surgery. Duncan's led a large proportion of the research on PCSO524, which is the active ingredient within Antinol. And so thank you so much to Duncan for taking a break from all your busy research projects, which are fortunately underway again now the lockdown is starting to ease. So that's great to hear. And we're also joined by John, who is Chief Veterinary Officer at CVS, who also just finished a full day of meetings and surgery. So thanks, John, because it's a pretty exhausting way to end your day. So at Vetz Petz, we invest a lot in training for vets, and John was very gracious in coming to run a arthroscopy course in Thailand with some key vets over there. So that was a really great experience for everyone who could be involved there. So as a brand, I'll leave it to these guys, but we're really excited to be able to collaborate on this session. One of our core missions at Vetz Petz is that we really want to drive owners back to their vets to receive the best advice they could possibly get on their pets' joint health. And obviously that's so much more challenging in the existing climate. So hopefully tonight we'll be able to dwell on some tools and you guys can take away some assets and things that might help for your consultations in the coming months with your clients. So yeah, that's it. I'll pass over to you, Duncan.
Great, thanks, Millie, and good evening, everyone. Actually, the first thing to mention is just looking at those pictures of John and myself. We both have a lot more hair at the moment for obvious reasons than we do in those pictures. So I think the first thing that we'd like to do is just acknowledge and thank Vetz Petz, the makers and distributors of Antinol, for setting up this webinar. And this is going to be more of a kind of a conversation back and forth between John and myself, but we hope to cover these areas, really, talk a little bit about the impact of COVID-19 on the assessment and treatment of OA, and then move into more detail on the diagnosis and staging of OA during these very unusual circumstances, and finish up with some discussion on the management. I think maybe one thing to start off with is just start to talk about the impact of COVID-19 on current operations. John, you've had quite a first-hand experience of this, haven't you?
Yeah, absolutely. And I'm sure all our colleagues watching have had a very disruptive time with everything that's going on. So it's been a tough time for everyone. So if you're working in the front line, well done and thank you for your efforts. I was in the clinic today for the first time, actually, and yeah, things have certainly changed in vet clinics over the last few weeks, very quickly and very suddenly. So I guess, Duncan, what over there in North Carolina, what have been, do you think, the sort of some of the impacts on osteoarthritis care, for example, that caused by this crisis?
Yeah, I think it's it is obviously because we're all affected. Some of us more than others. It's easy to focus on the negative aspects. No hands-on evaluation. We don't get that face-to-face opportunities for consultations. But maybe maybe just for a few minutes, let's focus on some of the positive aspects, because I think there are some positive aspects with respect to the how we think about and diagnose and manage OA. And I think probably for me, they fall into 4 areas. So I think owners are spending more time with their pets, maybe observing them more. And I think we'll come back to that. I do think that the challenge is potentially, even if we don't realize it, are improving our communication skills. And what I mean by that is, I think instead of now being face-to-face in a consulting room and maybe emphasizing the hands-on component, we actually have to listen and communicate and get information out of owners in these unusual circumstances. Has that been your experience, John? Or
yeah, absolutely. I think that's because we've lost that face-to-face, and we've lost the ability to examine the animal as we ask those questions. So I think some of the efficiency of what we do normally has disappeared. But you're absolutely right. I think it's brought a new focus, I suppose, because you've had your hands and the tactile element taken away. You have to really focus on doing the other elements really well. So I suppose we were talking about this in our group in the last few weeks, but we've really moved to trying to bring that efficiency back a bit. We've tried to use owner questionnaires, validated owner questionnaires, so CMI, clinical metrology instruments,
right.
because you can send those to the owner ahead of the telephone consult and get that information back, review it quickly and efficiently. And also using videos, owner captured video, but we'll maybe discuss that more. But there's, that does help to have that sent to you first. You don't want to be having lots of dialogue on the teleconsult with the owner or the video consult, trying to capture that live. It's a bit inefficient. Yeah. What about you? What's the experience in North Carolina?
Yeah, I completely agree. And for me, one of the most dramatic things is just realizing that we often do speak a different language to owners. And so focusing more on using language that owners understand, which I think is going to improve my communication skills. And then using these ancillary diagnostic tools that maybe we've underemphasized. You mentioned the clinical metrology instruments, these owner questionnaires, and the use of video from the home environment. I think is something that both of those, I think we will carry forward into the future.
I suppose one of the things that, we'll maybe touch on videos a bit later, but I was wondering whether people or yourself think that the numbers of dogs that we're diagnosing with OA problems has been affected by, the crisis and our ability to diagnose. So, what do you think what do you think vets should be expecting in terms of prevalence of OA? I suppose I'm asking. And I know we kind of probably have different views on this, but how prevalent is OA? And I guess maybe I sent you a slide earlier with
yes, here it is.
Some prevalence estimates. It's just rhetorical question to people watching. What do they think is the prevalence of OA in the canine population? And I guess my view is informed by other studies and maybe some studies that we've done over the years, and also how you define OA. But personally, I'd put it in the adult dog population somewhere between 8 and 20%. That would be my estimate. What about yourself?
Yeah, I'm going to go for a higher figure than that. I'll be a little bit bold here, and I'll say almost 40%. And I think,
is that based on research that you've done, or?
Yes, it's based on research I've been involved with that would put the figure around about 35 to 37% of all dogs. Now, in any studies, there are biases, depending on what practices are involved and how patients are recruited. I think there's no doubt it's at least 20% in my mind, and it's probably higher. And I think we'll find that figure will be higher once we get better at recognizing and diagnosing OA pain. And I think you mentioned something very important earlier on. Depends how you diagnose it. I think if we ask the question, what is the radiographic prevalence of OA, it's a lot higher. And a proportion of that is associated with pain. And that's really what we are focused on. That's what we're interested, because that is what is going to affect the individual patient. But I think, I mean, obviously I'm in a different geographical location. The influences may be somewhat different, but I'm going to put my money on a 35%.
And that's a clinical definition of OA. Yeah?
That's clinical. So that's OA pain. Yes. So that's not radiographic. That is pain associated with OA. And I think in many of those cases, we would be having some discussions about, okay, exactly, is there pain present or not, and how much pain is present? But I think that figure comes, I think that's an appropriate figure if we get better at diagnosing OA pain.
Okay, so I guess that just highlights to people that during this crisis period, we should be looking out for OA quite a lot, because it's there, whether it's 20% or whether it's 35, 40%, it's there and it's common. And maybe even in consults about other things, if we have time, we should be asking about mobility maybe.
Yeah. Well, let's talk about the consult in the era of COVID-19, John. How has that altered? What are the challenges, and how do we make that consultation beneficial to the patients?
Well, I guess, I think the crisis and teleconsults and video consults have just sort of magnified the challenge, really, because, we used to be able to examine the dog at the same time as us getting our history. And now we have to, find these tools to get the history from the owner. And, I think that for me, that focus on using the owner questionnaire brings standardization. It educates the client as to what you're actually looking for, and you get your history in a standardized format through that. So I think it can put back a little bit of the efficiency to use these CMIs, and so I absolutely embed that within all of the lameness consults I've done in this crisis. So I think that's helpful. I think there's still a challenge there though, which is obviously owners have got something in their mind, a complaint in their mind. They're trying to express that to you. So we need to ask the right questions too on the teleconsult. So I think it's worth having those standard nugget questions on a little script almost. If you're running in your practice, you could kind of all agree those questions. It might just add to your efficiency. And also I think cases are being handed across between clinicians more, because you might have a vet working from home or in isolation doing the teleconsult, and then another vet in a clinic taking up the case if it needs to come in. And so actually having that standardized history can really help. Right.
I do like the idea of this standardized approach with the clinical metrology instruments, but maybe just briefly, we'll come on to what these clinical metrology instruments are in a second, but what are they measuring? I mean, here are many dimensions that are impacted by osteoarthritis pain. So just, can you give us an overview as to what they're measuring?
Well, I suppose, yeah, I mean, that slide you put up there is trying to summarize the construct of osteoarthritis. So it's not a complete construct, but it's trying to get across the different ways in which a dog might be affected with OA, and the things that owners might notice, but we wouldn't always get time to question them about. And so the questionnaire is trying to address that, and trying to grab as much of that construct as possible and get that information. So yeah, that's your slide, but you've got chronic pain at the center there. I know pain is at the center of your whole career, Duncan.
Yes.
So, I mean, talk us through that slide and what you're getting across in that slide.
Yeah, and I think I put this slide in because I think just going back to this one, we have to be a little bit careful. Osteoarthritis can be associated with pain. It's the pain we're interested in. I mean, for sure, we would like to stop the disease process because that can be associated with pain. But it's pain is at the center of everything, John. I mean, it really is.
Yeah, well, I know it's coming up for 29 years since we met, Duncan, and you said that then, and we're still having that debate. So it's good that we're keeping that going. But you're absolutely right. I mean, clearly, I wouldn't disagree with that, it doesn't matter whether you've got OA on a radiograph, if there's pain associated with it, and that's when it really matters. Yeah.
Right.
I'm coming around to agree with you.
Wow. Okay. So I hope this is being recorded because we need to capture that. So what this slide speaks to is that chronic pain impacts multiple different dimensions. Dimension is function, it's sleep, it's cognitive function, and many of these, I think, can be the information about these dimensions can be captured by these clinical metrology instruments, which are a series of questions. And these have been developed in a way that, for the questionnaires that have been appropriately developed, makes these questions valid and a sensitive measure of those dimensions that you just saw up on the screen. Now, John, you have spent a long time developing one of these questionnaires, the LOAD. Do you want to talk a little bit about that process? And maybe we'll just dip into validation a little bit.
Yeah, I mean, you can maybe skip on the slide there, but yeah, there is a process. It's borrowed from psychology, of course, the science of psychology, but it's going through a standardized process of validation, and that is a continuous process. It never really ends. But
I think you had a slide of.
Yeah.
Here we are.
So there's a starting point for that, and then pilot tests, and then construct validity and different types of validity testing, different types of statistical analysis. You might need to revise your questionnaire in the light of that, and then testing the reliability, testing it against another gold standard, and then seeing if actually it's responsive. So you do want a questionnaire to be reliable, but not so reliable that it doesn't respond to a signal. So we want owners to be able to tell us if things have got better or worse or stayed the same. So we want confidence in the instrument for that. So that's the process. I'm a very slow worker. It took me about 20 years with colleagues, and I must recognize those colleagues, particularly here, yourself, Duncan, and Ben Walton and Emily Cowdroy, because this paper, 222 dogs, a lot of work, and also comparing to some of the other instruments, but also importantly comparing to a force platform, so an objective measure of lameness. So that's an open access paper, but so if people are having trouble sleeping in this crisis, they can go away and read that paper.
Let's move on and talk a little bit about what the LOAD can and can't do, or what these clinical metrology instruments can and can't do. Now, I think it's fair to say, John, that we both use these fairly broadly to assess patients, but tell us a little bit about what the LOAD is actually measuring and maybe what it doesn't measure. Yeah,
so, well, obviously it's measuring and it's by proxy, of course, so that's an important thing, that the owner needs to be the same person each time completing the instrument, and it's obviously giving you information about the owner's impression of their dog's mobility and in different contexts. And I know you've also been involved in development of these instruments as well, Duncan, and there are different strategies. I know that you did the client-specific outcomes measure, where the client would actually list the most important aspects to them, and then you would measure those over time. So there are different strategies that you can use, but they don't measure everything, of course. And we do need to bear in mind that there is an impact from the owner's personality type, let's put it that way. Some owners are much more relaxed about their dog's lameness, and other owners are much more anxious, and so the scores can vary a little bit by that. So it's important the same person completes the questionnaire each time.
And
I'm not sure I've fully answered your question, so I'll actually throw that back to you and say, you know, what's your opinion of, you know, in terms of your own question there, what would be your answer?
yeah, I think, you know, if you just think about my little world on a given day, I'm just dealing with OA and I'm using these questionnaires and they work great. They distinguish normal versus OA dogs. I think the reality is, though, that because they are measures of a variety of those dimensions, such as mobility, activities of daily living, they will pick up non-OA cases. I think that's, you know, that's important to remember. We don't have any questionnaires that are absolutely specific to OA. And so, yes, when they apply to a dog with OA, they tell us about that dog. But if a dog has neurological disease, you're also going to see some positive numbers on these instruments. And so I think these are extremely useful, but we don't want to go away with the idea that they are absolutely specific measures of just OA.
I think that's really important. You know, I had an owner last week contact me, and she described her dog as wobbly and unable to walk. And actually, you know, I got very worried. It was neurological, but when she did finally see a vet, the dog had hip pain and was lame. So yeah, the owner language that you referred to earlier,
yeah,
is really important, because they interpret things in a different way sometimes. Yeah.
Yeah. And when we're using the load, we're going to, and we'll come to, I think, an example in a moment, but we're going to end up with a number. So what we're talking about here is sending out a questionnaire to the owners. They complete it, and these questionnaires are all designed to be very easily completed by owners. They complete it, and we get a number. What does that number mean, John?
Well, yeah, and you know, the caveat being that it's got to be the same owner, and you know, different owners can slide up and down this scale a little bit. But if you look at populations of owners, as we did in this paper, you know, I think this graphic kind of helps you categorize and stage the severity of the problem. And we won't say it's OA, because it could be just a mobility problem, and it could be caused by other things in this crisis time, as you pointed out. But it's putting a number on it, and I think that's important, because in this period of time where we can't examine the dog directly always, when we do a repeat of this measurement, we'll be able to pick up whether the score is going down, maybe in response to what we remotely prescribe in terms of pain relief, or whether it's going up. And maybe it's those ones where it's going up despite what we've done that should set off the alarm bells. And I think particularly at a time when cases are being passed from one vet to the other, maybe because we're working split shifts or on rotas, then that's really important, because the owner is the one consistent thing in this.
Right. I think that's a really good point. In my experience, the score, the severity of OA doesn't fluctuate that much. And so if you're starting to see an increase in these numbers, then I think, you know, that should set off some alarm bells. Now, again, going back to my world, because, you know, I live in my world, I like the idea of using the... Yes, I like the idea of using these questionnaires in the purest way possible. So, you know, they were developed as paper questionnaires. I like to print them out, sit the owner down, have them complete that. But obviously that entails a face-to-face conversation. Talk to us a little bit about how your experience of using the load over the telephone, and then we'll move on to let everyone know where they can get the load from.
Yeah, I think one of the things I learned with the teleconsults is that you actually have to be more prescriptive with clients as you send them the questionnaire, because if you're face to face, they can ask you a question if they've got if they're not sure about what to do, and you can answer it immediately. But if you're not face to face, you need to give them instructions, and so you've got to tell owners to make sure they can answer every question. and only tick one box in every question, all those things. So I've actually done a little document that I send out to clients. This is how to complete this questionnaire. It's just a bit more detailed than the general guidance.
Yeah. My experience is it's doctors, it's MDs who want to put the X between the two boxes.
That's right.
You know?
Yeah.
And so I think, something that a question always comes up with me is, well, the load is this questionnaire, it works, it tells us about the impact of OA, where do we get it from? And this is, you should talk to this, because this is the UK portal.
That is, yes. But I believe, basically load is licensed to Elanco on a global basis. So contact your local Elanco rep if you want a copy. They'll give you a free copy of it. And but I think different countries will have a myelanco.com portal around the world. So contact Elanco and get a copy. That's the easiest way, and it's free to use.
And this is something that can be downloaded, emailed to owners. They complete it and send it back. So that's what we're talking about here in terms of it, including that as part of the OA consult.
Yeah, and preferably ahead of time, obviously, because it saves time then live.
Yeah. So maybe we'll just. Do you want to talk to these two cases briefly, John?
Very briefly. I mean, just to illustrate load, really. So if you let's play that video. People can just watch this dog. It might be jumping up and down and a bit jumpy, this video, but hopefully people get to see it. This dog's walking fairly briskly. It had a load score of 13, but the force plate here, which is in the middle of that runway, is telling us that the dog had an asymmetry index of 17.8, and that's a measure of hind limb lameness. So just remember those figures, 17.8 and 13. And if we play this dog, one thing you notice straight away, this dog's moving more slowly. As it turns to come back to us, you'll see it looks rather laboured, looks quite lame. Its tongue's hanging out. His economy of motion is not as good. His asymmetry index, though, was 15.2. So the force plate is telling us that dog actually is less lame. Whereas the load score is 23. It's higher, so telling us the dog's worse. And it's just I think, the question is the CMIs give a holistic capture of the animal compared to the unidimensional nature of a force platform. So it's just really to hopefully get across that these questionnaires do have some value, and we know that they can show a treatment response in clinical trials, and you've done a lot of that work. And so, you could probably tell us, Duncan, in terms of those trials that you've done lots and lots of them, what are the strengths and weaknesses of the CMIs in those OA trials that you've done?
Yeah, I mean, I think you make a very good point. When you say that the CMIs capture the whole dog, information about the whole dog, and really that's what owners are interested in. They're interested in the impact of OA pain on the whole dog. And so actually, I like running trials with these owner questionnaires, because we can recruit dogs with OA in multiple sites. And when we're looking at systemic treatments, they give a very sensitive readout of changes as a result of those treatments. But I think those two videos bring us on to something else that we have talked about. As we piece together the jigsaw of how do we navigate and manage OA during COVID, taking videos, OCVs, as I like to call them, the owner collected videos. John gives, just for everyone's benefit, John gives me a lot of grief about these acronyms. He says I've become far too Yankee-like.
Oh, but, you live in America, Duncan, that's allowed.
Okay, so tell us a little bit about your thoughts on collecting these videos, John.
Well, I was just, again, I've asked owners on before teleconsults to collect some video of their dog. And I suppose over the years, I've done that for follow-up of cases and never thought too much about it. But actually, when you're trying to make a diagnosis from a video, it's really brought it into focus. So I guess I've now developed some advice that I send out to owners so that I can get the best quality video back. Because if you leave it to the owner to decide, they don't know what we're really looking for. They probably, you know, they're not experts in taking good videos of dogs walking for mobility assessment. So, you know, I try and guide them, find the right environment, a quiet environment, no distractions, nice level surface, good lighting, with a light background if you can. The last thing you want is a black Labrador against, you know,
Right.
in a dark room or in a wood or something. You can't see it. And, you know, you want the lameness tends to come out more at the trot, gait. So you want to try and get them to trot the dog. If they walk briskly, generally that should be enough. And in terms of guiding them on gait, there's a link there. So it's not my video link. So whoever posted that link, thank you to them, because it's a really nice, clear video for owners as to the different gaits of a dog. That's helpful. And then try and give them some guidance about actually what you want them to collect for you. So break it down into relatively short files, because one of the obstacles is then the upload of the file back to you. And I try and get them to walk or trot the dog away and back, and do that at least a couple of times. And then also round in a triangle, so you can see the dog side on, from behind and coming towards you. So they're my kind of guidance points. And you must have had lots of experience with this, though, because you've even got an acronym for owner collected videos. So, you know, what are your tips?
Well, so yeah, I mean, I think this is a great set of directions for owners. I think other tips would be to try and get the camera at dog level. Try and encourage owners not to drag the dog on the leash, but, you know, allow that lead to be slack. I do think my experience is you have to be patient. And I'm reminded of last Sunday when I was trying to instruct my brother to collect video of his dog. And he has a dark greyhound. The first video that he took was of the dark greyhound in a dark room. The second video was focused right on the greyhound's feet. And, you know, I mean, I've always, maybe, no, that's not true. I've not always thought of my brother as intelligent, but, you know, assuming he is somewhat intelligent, I could feel the frustration building. You know, why couldn't he just understand what I wanted? And so I think your approach of writing down these instructions, communicating these is excellent. I think these are all great tips. I think we do have to overlay that with a degree of patience. We're not always going to get back perfect video. That said, all video is useful. We learn so much by looking at video of these pets in their home environment. The one thing I have, I'm not sure I have a very well-developed method for this. The one thing I've struggled with is file formats, transferring files, storing them. How do you manage that, John? And how do you integrate those into the health record?
Yeah, so I mean, I guess that will vary for people, but you know, I'm not great with IT, so I get other people to do that for me. But you know, luckily we have a PMS where you can upload all sorts of different file formats into the PMS, and I would guess a lot of modern PMSs allow that now. Right. Giving clients guidance on the file transfer is useful, though. So use your preferred, you know, file transfer service. Yeah. What do you use? Dropbox or something like that, or one of these prepared?
Thanks for calling me out on this. I use a combination of WeTransfer, Dropbox, Google Drive. I've really not. I should have settled on a platform or format, and I think that's actually an important thing, so that the process is slick and doesn't frustrate you or the people you're asking to send you videos. How about viewing these videos, John? Do you view them on your phone or?
No, I mean, I like to make sure I'm looking at the nice big screen on a Mac, you know, so you like looking at diagnostic images, isn't it? You want the best screen you've got available.
Right.
But I do like to use an app to slow the video down if necessary, particularly for small dogs.
And so here we have John, this is a dark dog in a, well, no, it's a dark room.
This is actually, I think, was a high-speed camera, so that's why it's a bit dark.
Okay.
But this is a video that Ben Walton collected during that trial that we did, and you know, it just helps to slow the gait down. I mean, this dog's lame on every limb. I mean, it's in musculoskeletal meltdown, but it allows you to see that this dog has a very disrupted gait cycle. And again, you know, its tongue is hanging out, its demeanor is one of a dog in pain and discomfort. Yeah. So there's a lot of clues in the video, not just on the lameness, but also on the, you know, how sprightly is the dog moving, is its economy of motion there. I think there are other cues that you can get from these videos. Anyway,
I've got a quick example here because, as you know, it's always sunny in North Carolina. So we can go outdoors, another slow down video. So I really like that as a tip, John.
Yeah, that's nice.
Should we move on to talk about treatment for a little bit?
I think we should, because I'm sure people want to hear a little bit about management.
Okay, so what? Let me maybe throw you a question here. In this period of COVID-19 and remote diagnosis and remote prescribing, if you had a new case of lameness, it's likely OA. What duration of treatment are you initially going to prescribe?
Yeah, I mean, that's a good question. It's likely OA. I mean, I don't know whether you could have that confidence with a new lameness to say that at the moment. I think you've got to keep a very much an open mind, I suppose. But yeah, I think in normal times, treatment of new lameness would very often be empirical to start with, wouldn't it? Because I guess we assume soft tissue injury is very common and will probably go away. And so, you know, I think that sort of duration that we might use for a soft tissue injury is reasonable. So a few days, maybe 7 to 10 days, something like that. But I think the more important thing is to book a follow-up teleconsult and ask the owner to fill out another questionnaire and send another video.
Right.
What we need to be picking up here are the potential misses in what we're doing. You know, that dog that's actually got something quite serious going on. And so I think a review within a few days is the important thing there.
Yeah, I just want to pick up on something you said there, John. So I think it's important to emphasize when we're observing from afar, there are certain things that are probably not OA. You can never be too absolutely cut and dry about this, but a non-weight bearing lameness is probably not OA. Intermittent non-weight bearing lameness with associated yelping and screaming is probably not OA. Would you agree with those?
Yeah, I think in general terms, I mean, you're absolutely right. You know, if it's very severe as you described there and persistent, you know, I think some dogs with OA can be very severe, but it's usually for a day or so.
Right.
And then it will go back down to that normal, you know, mid-range lameness type thing that a lot of OA dogs will have. But you're absolutely right. I think they're the ones that have to set the alarm bells going, and the vocalizing in pain, that's not normal for, you know, most dogs with OA wouldn't do that. It's a different type of pain probably.
Yeah.
Would you agree with that?
Yeah, no, I completely agree. I mean, I think if there's a non-weight bearing lameness, it's we really should be shifting things like nerve root entrapment, fracture, septic joint, higher up that differential list. You know, and also particularly going back to the comments about the clinical metrology instruments and the follow-up, if those scores are increasing, then I think those become more urgent cases that should be seen.
Yeah.
And, you know, consider, if we can, move to a face-to-face consult for those.
I agree. You know, if they're going over that threshold, that's the trigger, isn't it, for, you know, come into the clinic for a socially distanced examination or workup. Yeah. And in terms of response to treatment, Duncan, can I ask you, you know, what would you use you know, what would be your thresholds, you know, with these tools? Are you asking for repeat video as well? Is that not, you know, what you're doing?
Yes, so we have owners complete the questionnaires, the clinical metrology instruments again. I try and get repeat video. Normally, the second round of video is so much better than the first. You know, there's a learning process here. But I think, and then I dovetail those two things together to make an assessment of whether my instigated treatment is having a positive effect, as well as with, you know, you mentioned earlier some of these standard questions that we might ask, as well as with questions about overall, how do you think things are going? Because there's a lot that we don't know how to capture in a very specific way. But let's go back to treatment. And what would you consider? So we're really talking about remote prescribing.
Yeah.
What would you consider safe options for treatment? What is, you know, what options are on the table?
Well, I don't know what's happened where you are in the States, and probably differs state by state, but certainly here in the UK, our regulator has relaxed the remote prescribing to allow us to give treatment remotely, over the telephone, over video consult. And so, you know, I think, you know, let's use the analogy with ourselves. If we were in musculoskeletal pain, what would you reach for? Well, you'd reach for those things that are over the counter, as it were, that you've already got in your cupboard. And I suppose the equivalent for dogs is things that we know are safe, but will give some pain relief. So, you know, whatever category you think of, I think you want something that's safe primarily, because we don't want to be causing issues with that. So I think that's safety probably comes up the agenda a bit at the moment. Maybe that's just my personal viewpoint. But we want something that we know is effective, because, you know, we kind of want to make sure we relieve some pain if there's pain there and there's evidence.
So let me ask you very specifically then. You mentioned safety. Does that take non-steroidals away as an option?
No, not for me. Not for me.
Right.
It doesn't. No. Because for the vast majority of dogs, that, you know, absolutely they are safe, and so I think we want to risk assess things, of course.
Right.
Clearly, it's, you know, if you've got a young, healthy dog with a lameness problem, it's very different to a very elderly dog. You know, it might have comorbidities, so we want to make sure we're checking for those in the history at least. But no, I think, you know, if I was in pain, I'd reach for an anti-inflammatory and an analgesic, and I think that's reasonable. What do you think? You're much more an expert than me on pain control.
I don't know about that, John. I completely agree with your comments, and I think, you know, maybe if there are any benefits to this COVID-19, I think for myself and many of my colleagues, it's focused that conversation around safety. So I do think non-steroidals are very appropriate to use, but I think many of us in this geographical location have relied on blood work as a crutch. You run blood work, if that's okay, everything's good, and you don't worry about it. And now I think we're having conversations where we're explaining more about possible side effects, which I totally agree are at a very low incidence, but we're having better conversations about that, which I think is more appropriate than just relying on blood work panel. And I think, you know, we're also making maybe better use or thinking more about the other treatment options, such as appropriate exercise, making sure, you know, as we're all sitting around at home, not doing a lot, we're not eating too much. So making sure the calorie intake doesn't skyrocket, thinking about utilizing the omega-3 fatty acids, other marine-based oils, and, you know, other therapies that we can instigate in the home environment.
Yeah, and I think,
but I know one question, John, which is,
they're safe as well, aren't they? And
right,
you know, that all fits with the safety message too, doesn't it?
Yeah.
And I suppose one thing that might be influencing incident OA at the moment is that, you know, a lot of dogs are probably getting more exercise than they've ever had.
Yes.
Because, you know, in the lockdown, everyone, well, certainly in the UK, you could go out for an hour of exercise in the lockdown, and you know, a dog was a great excuse.
Yes.
So each family member, or, you know, different family people, my uncle was coming around to our house to borrow our dog every day, you know, so he was getting an extra walk every day. This will be happening, and yeah, so it's always worth asking about that, isn't it? But you're talking about exercise. What would you generally say about exercise and OA management?
So I firmly believe that exercise is analgesic in and of its own right. It produces pain relief. Although in order to exercise, you often need some pain relief. So I think the non-steroidals and exercise go hand in hand. The other important point to make about exercise is to gradually increase it. Now, you know, on that note, for years, I was saying to clients, you know, dog has OA, that is non-steroidal, go home and gradually increase your dog's exercise. And of course, they had no idea what to do. Because, I mean, what does gradually increase exercise mean very specifically? And so another thing which I think I've found over the last couple of months is I've been sending owners almost like a training program. So we have a conversation, how much exercise is your dog currently getting? Okay, well, we're going to start, if it's truly, you know, 5 minutes twice a day, we're going to then for a couple of weeks increase that to 10 minutes twice a day, then maybe 15 minutes twice a day. And so actually writing that down so that they have almost a training plan to follow, I think is a very useful thing. So
you're like the sort of canine version of Joe Wicks, are you? You probably don't know who he is, but
I don't.
No, he's doing free training classes for everyone in the UK every morning. So
right.
Thousands of people following him. So I guess a question that comes up a lot, though, Duncan, and you are the king of pain control. If the first, you know, those options that we talked about, if you've used those and they haven't had enough impact on a particular case, what would you reach for next in your second line of treatment, given the sort of remote prescribing situation?
That's a great question. I think one thing to emphasize before I tackle that difficult area, it is a difficult area, is that I think we need to be prescribing the basic treatments, the non-steroidals. Think about exercise, omega-3 fatty acids for a prolonged period of time. That's when we're going to see the benefit. Now, if we're not seeing the improvement that we want, then I think the first thing we should do is reevaluate that patient. You know, have the owners complete the clinical metrology instrument again. Let's get some more video, maybe some more in-depth video, really asking the question, is this OA that is not appropriately responsive, or do we think there's something else going on? And then, you know, we're into this discussion about tramadol, gabapentin, amantadine. We know, the harsh reality is we know so little about whether or not there's any efficacy associated with those in canine OA. One little study on amantadine that showed some positive effects when it was used with the non-steroidal. I think we're starting to realize now that tramadol on a population basis is not effective. And that evidence has been building over the last few years. Gabapentin is a difficult one. It's, you know, gabapentin is the new tramadol. Everyone's reaching for gabapentin. And I'm saying this a bit tongue in cheek, but apparently it cures everything. And that should be a red flag. You know, nothing cures everything. And I think that we are overreaching for gabapentin because of a perceived safety. So it's almost making us feel better, but we're not asking the hard question, is it actually making our patients feel better? What do you think, John?
No, I completely agree, actually. Yeah. I see a lot of dogs that are receiving gabapentin now. And, when you ask, or before this crisis, when you'd ask owners how much effect did it have, quite often they say, couldn't really tell.
Right.
I think we do need more information on its efficacy in OA pain. I'm not convinced at the moment, but that's obviously my opinion, and I'd rather see good data. Yeah.
Yeah, I mean, I think the future will be a scenario where we can better subphenotype these OA pain patients in order to predict what is going to be efficacious. Are the non-steroidals going to provide appropriate efficacy? Do we need to add in some centrally acting analgesics such as duloxetine or something else? But that requires us having the ability to subphenotype really understand what is driving pain in those particular patients.
Can I ask you then maybe just a last question, I suppose, before we go into Q&A, Duncan, because there are some questions that have come in. And this is maybe not for the crisis time, I suppose, but, where you're heavily involved in OA research, therapy research, where do you see things, moving and changing in the next 2 to 5 years, let's say?
Yeah, I mean, I'm not sure I have, I'm not sure I have a crystal ball here, John, but I do think there's going to be a lot more emphasis on developing information around intra-articular treatments. And so I think we're going to see more emphasis in that area. Those are going to be developed better. I think, and I'm jumping around a little bit here, I think we are, and possibly as a carryover from some of our experiences in the last few months during COVID-19, there's going to be more emphasis on client communication, on clinical metrology instruments, and on observation of these patients. Stepping back and observing the whole patient, gathering information about the whole patient, rather than just diving in and focusing on a single joint. And that is not at odds with my comments about intra-articular treatments. I think the intra-articular therapy is an underserved area. I think there's going to be a greater recognition that OA is a young dog disease. It's driven by developmental disease in the main part, which therefore means it's initiated in young dogs. It is essentially a young dog disease. And so we'll shift the diagnosis back to those younger dogs, and hopefully by treating those appropriately, improve the long-term life of those patients that we are treating. I think on the systemic treatments, the first thing we're going to see are treatments that address the role of neurotrophins in chronic pain. So anti-nerve growth factor is neurotrophin, anti-nerve growth factor monoclonal antibodies. That's probably in the pain world, that's probably the most exciting therapeutic development in 25 years. And that's not overstating it.
Do you think this crisis might have delayed the launch of those products, maybe? I genuinely don't know, but just interested.
Nor do I. I mean, I think they're probably at a process where the clinical trials are done, and they're going through the approval process. But we'll wait and see.
Yeah. It's just difficult for companies to launch products, isn't it, at the moment when they can't.
Right.
You can't hold launch events or visit practices and clinics, and it's going to have all sorts of implications, isn't it?
Yeah. And there are several other exciting treatments coming down the pipeline. So the future is all about pain, and the future looks bright.
Very good.
So John, should we take some questions here?
Yeah. So Millie might want to rejoin us now. Millie, thanks to you and Vetz Petz for sponsoring this event. I'm sure everyone is grateful. And there are some questions there. So do you want to?
No, that's brilliant. Thank you so much, guys. That was really informative. Maybe I could just start by sharing the poll results, because that can give some sort of quite interesting insights. So just to summarize, and thank you very much to everyone who voted when they jumped on the call. So as a summary, 72% have seen diagnosis of OA stay the same or go up. 90% agree it's appropriate to diagnose OA remotely, at least in some cases. And 75% feel comfortable recommending mobility supplements to help treat OA, which is 15% more than would feel comfortable recommending non-steroidals. So quite an interesting set of stats there. What are your thoughts on that, guys?
Yeah, I think that probably is, it goes back to what I was saying about safety, because we haven't got that same ability to examine the dog. So safety's come up the agenda, probably, I would imagine. Duncan, do you think so? Or?
I'm sure it has. I mean, it's certainly, that's my personal experience. And I think it's, because when we can't do the things we're used to doing that we rely on, the human nature is to step back and question, and safety is something that we are concerned about. And when we don't have ready access to blood work, we can't put our hands on these patients. I think that does rise higher on the list of concerns.
So in light of this, what kind of COVID-19 friendly treatments do you think the vets, there'll be a trend in vets leaning towards? Obviously, given that the complexity that non-steroidal therapies are a critical foundation of pain management approaches, but for vets that might be concerned with the risks or feel that they haven't confidently been able to do the remote diagnosis or not have the whole picture, how do you think they can manage that?
You want to set off for that one, John?
Well, I was going to leave that one to you. It's tricky. It is tricky, and I have a lot of sympathy with colleagues out there at the moment, because we're working in uncertain ways, I suppose, at some extent. But I think the majority of first line things that colleagues would normally reach for in an OA dog are still perfectly relevant. So I don't think people, changing exactly what you do, or a big shift in what you do might be just as risky because you don't know as much about those treatments. So I think sticking to, the things that you know and trust, and also you know the problems that can occur with those things, and the expected response, I think can be helpful at this time for a clinician. I think changing too much of what you would normally do might lead to more errors.
Yeah. I agree, John, and I think it's just it's just it's thinking through it slightly differently, and having slightly different conversations with owners. But those those four pillars, if you like, as I describe them, of pain management in OA cases. So we're talking about the non-steroidals, an effective analgesic, exercise, and there's a question about exercise that I want to come to in a second, and then making sure that these dogs don't get overweight at the moment. It's going to be difficult maybe to control and reduce weight. And then the omega-3 fatty acids, there's emerging evidence around marine-based oils. But I think those are the four pillars for me. And that's where we really need to maintain our focus. There was a question about exercise, and I want to see if I can find it here. Exercise possibly causing more, there we are. Can you give more detail about increasing exercise? Can it cause the dog more pain? I think that's a really good question. And going back to my earlier comments, I think the exercise has to go hand in hand with pain relief to allow exercise. So those two should go hand in hand. So the non-steroidal, often what I'll do is I'll provide non-steroidals for a week without changing anything, 10 days without changing anything, then gradually start to increase that exercise. And I think, I have John comment on this, but I think for the majority of OA patients, increasing the length of a walk by 5 minutes each week, say there's 1 or 2 walks a day, you increase it by 5 minutes each week, is a very modest way to increase exercise, and overall I would say a very safe way to increase exercise. What you don't want to do is dive in with a dramatic increase in exercise, or you'll end up like me. I do nothing during the week, run around like crazy at the weekend, and then I can't do anything the next week. John?
No, I agree. That sort of 5 minutes a week, that's how I'm going to ease myself out of lockdown, having done not much for 8 weeks. But yeah, I think you're right. I mean, there are some dogs out there, though, that are so severely affected that actually they can't do it. They just, you know, they just refuse to do anymore. And I have a lot of sympathy. And then maybe for those dogs, we need to think about changing the type of exercise a bit. You know, and it's difficult at the moment, but maybe swimming for those dogs might be a little bit easier or something like that. So I think each dog is slightly different, but I agree with you, Duncan, that increasing at that 5 minutes each time per week is generally, you know, for the majority is okay. And there's loads of evidence in human medicine that these building up exercise over time, over a period of, let's say, 8 weeks, is beneficial for OA. There was a question here. Millie, I don't know, do you want to choose a question now, or we'll let you choose a question?
So I was just going to revert to a comment that Duncan said about sort of trends you see over the next 2 to 5 years of sort of increased communication between practices and their clients. Obviously, without that face-to-face engagement, it's harder to get the education across about OA management. But we did have a question that was, if you wanted to proactively start a conversation about OA with an owner, what's the #1 question you would ask, and is it different for dogs versus cats?
To proactively start a conversation. Well, I can give my input on the first part of that. So proactively open up a conversation. I think, honestly, and this is my experience, a very easy way of doing that is to have them complete one of these clinical metrology instruments. And that then gives you something written down, tangible, to frame a conversation. You know, that allows you to open up a conversation. And I think sometimes not every owner is open to that conversation at the first time, but I think having something written down, rather than it be a conversation that is almost totally off the record. You know, you ask, how's your dog jumping into the car? And the owner says, oh, you know, struggles a little bit sometimes. And if you jump in and say, oh, must have OA, let's have a conversation, I think that can put them off. But having something that's written down, something they can see, they completed the questionnaire. And then you can take them through that and explain that, you know, if they've completed it in a way that suggests that there's a higher score, you can take them through that and explain that some of these signs may be due to OA, may not be, but this is something that we need to talk further about. John, what do you think?
Yeah, all good points. I suppose one thing about load, for example, I know that questionnaire in detail, is it's not really a screening tool because it does assume there's a lameness. So that may not be the right tool in that instance for that opening question. And I'd also say I don't really have a #1 question, so I'm sort of dodging the question really, because, you know, if you go back to the construct of OA slide that I put up earlier, OA can affect dogs in different ways, and that the first way that it affects a dog isn't the same for every dog. So I suppose if you're really looking for the first initial signs, then sometimes inactivity stiffness is the first thing that owners will notice. So maybe prompt them to think about that. But sometimes it's just slowing down on walks, not necessarily lame or stiff, but just slowing down. And we talked the other day about, you know, whether we should be developing tests that actually time the ability of a dog to walk a certain distance. They certainly do that in people with OA and frailty assessments. So in people. So I think it's going to be different for different dogs. You probably need to ask 3 or 4 opening questions to get a bit of a handle on whether there is a mobility issue.
And how early do you think you and future vets in the future will start asking people, you know, depending on the dog's age? There was a question about someone in the lecture who's went to a seminar in the States who said that they have been screening dogs from the age of 9 months for OA over there. So at what age do you think you'd start asking on average those mobility type questions to see if there's an OA issue?
So I'm going to jump in here and because this is like a little soapbox thing for me. So all of our focus has been around the another one, yes. All of our focus has been around the middle-aged and older dog, and I think we're actually, you know, if we use the tools at our disposal, we're pretty good at that. But as I commented earlier, OA is driven by developmental disease. It is initiated in younger animals, and it is present. And I think, so John, you used a few words, economy of motion. And I think in younger animals, what we often see is the same ability to perform a task, but with increased effort, a decreased economy of motion. So for example, you know, a dog with hip dysplasia and therefore hip OA, has hip OA at 12 months, can still move along a flat surface, can still go upstairs, but with more effort. There's that movement of the pelvis from side to side. So that's a decreased economy of motion, decreased efficiency in motion. And I think so those are obvious when you start looking for them and recognizing that they're obvious signs, I believe, of OA pain in that younger dog population. And I think once we recognize that, once we embrace that, then when we look, not should we be looking for OA in young dogs, when we look for OA in young dogs, we will find it. So maybe to directly answer the question instead of pontificating around in circles, should we be looking for OA in young dogs? Yes. As young as 9 months, absolutely.
Yeah, I agree with you, Duncan. I would just add to that that younger dogs, of course, have more inherent energy, and therefore you need to be a little bit more critical when you're looking for OA in younger dogs. It won't be as obvious even on the owner questionnaires, because you know the dogs will still be very keen to exercise, right, even though they might have a lot of joint pain, because of that natural energy of youth that I remember from a long time ago. But of course, as dogs get older, they also, you know, get sarcopenia and all of those muscular changes that come with aging and also having OA. So it's easier to pick it up in middle-aged to older dogs. But I think, yeah, we need to be more eagle-eyed in those young dogs to pick it up. But it's definitely there because we know they have this developmental disease. Yeah.
Mm-hmm. So for clients with younger dog who presume or anticipate due to breed propensity or that kind of thing, that their dog might end up having OA at a later stage, who then want to look at early management and, you know, consider nutraceuticals. A question from an attendee has been that, is there a nutraceutical that you feel is more safe or effective than others at the moment that might come into play in those early stages?
Yeah, that is a, yeah, now I'm going to upset some people here. So I think there is, and I've learned because I've upset owners in the past. So for a variety of different reasons, owners, veterinarians can be married to one or other supplement. The harsh reality is there is almost no evidence that these supplements do anything beneficial. They certainly don't do anything to alter the disease, the progression of disease, which is how they're often touted. And then you layer on top of that it's a completely unregulated industry and you really don't know what you're getting. So I think for me, and maybe I'm taking a too simplistic approach, but I think for me, I look at what we do know. And I'm going to ask John to comment, but I think there's reasonably good evidence that the omega-3 fatty acids added into diets or as part of a diet can make a measurable difference. You know, I think there are still questions around, you know, is it enough? How much? And then beyond that, I think there's some emerging evidence that other marine-based oils, other marine-based extracts may have a beneficial effect. But that's my opinion. John, what do you think?
Well, I tend to agree. Well, you know, Duncan, I think it's very difficult to compare between different products, let's say. I think categories, I agree, you know, when we did a systematic review a few years ago, and it's old now, it's 10 years old now, probably someone else needs to do, oh, you could do another one now, Duncan.
Right.
You know, the essential fatty acids did have, you know, of all these sort of nutritional supplements, the fatty acids had the strongest signal. Yeah, for sure.
Yeah. And it's, I mean, it's a huge industry. Yeah.
Okay. Do you want to take one more question, Millie, do you think? Or?
Yeah, I think we're nearly there. One quick question before we wrap up. What is your opinion in the use of paracetamol together with non-steroidals in dogs with OA?
That's a great one, because I think John and I differ on this.
Okay, good. We can end with the disagreement.
John.
And storm out of the room.
Right.
Yeah, well, I you know, I think actually paracetamol or acetaminophen has been around for decades. And it's interesting that, you know, studies are still done on it and in human medicine. And actually viewpoints have continued to shift in different areas of human medicine. We don't have much data in dogs, of course, but so, you know, I think for certain types of pain, there's evidence that, you know, along with a non-steroidal, you might get a synergistic effect. But equally, there are other studies that show back pain, for example, in human medicine, no significant effect from paracetamol. And there are question marks over knee and hip OA. But the dental world seem to think that it has a useful effect on dental pain alongside a non-steroidal. But I think we're right out of time there now, Duncan. So yeah, you're not going to get a chance to disagree with me.
There we are.
I think it's time to close this. No, I'm joking. What's your viewpoint?
Actually, you know, maybe I had only selectively listened to you in the past because I thought we were going to disagree more. So I think we're probably on more or less on the same page. For me, I think, and this is partly being in the States where there are, for a variety of reasons, more concerns about safety. I'm maybe more focused on the question, what happens when you combine a non-steroidal with acetaminophen, with paracetamol, in terms of the effect on the GI tract? I mean, we've heard for years, don't give two therapeutic doses of don't give therapeutic doses of two different non-steroidals. Don't use non-steroidals and steroids. And I think for me, that's an unanswered question, the use of non-steroidals and paracetamol. But I totally agree with your comments on its potential use as an analgesic dependent on the pain state, which honestly, I think we've still got a lot to learn about in veterinary medicine.
I sense we could speak for another hour just on that topic, Duncan, so we probably ought to leave it there.
I think we could.
Thanks, that's all really good. So if I can just ask a final thing before we wrap up, I guess it's always nice to finish on a positive note. I was just intrigued to ask if there was sort of one final key takeaway that vets could, you know, take home with them tonight. I heard a phrase on the Veterinary Innovation podcast a few weeks ago, which I thought was really interesting, which was, now is a time to capitalize on change management in the face of lowered resistance. And I thought that's a really interesting point, because suddenly people can't stay in their same routines as they were before, and everyone's having to innovate and think outside of the mold. So, you know, what do you think is a big opportunity that's actually a great win for vets sort of coming out of the other side in the new normal in the OA space?
After you, Duncan.
What you said, Billy, sounded really good. I can't remember it. If I've listened to the question correctly, I think it's the experience of having to rely more heavily on tools that were already there, on approaches that were already there for diagnosis and capturing information from owners. And so I go back to the clinical metrology instruments and the use of video. And I think that, you know, if those can become a more substantial part of our diagnosis and follow-up in OA cases, I think that'll be good.
Mm-hmm. Okay. John, anything?
Yeah, no, I think this experience will have taught us those things, and hopefully that some of those new habits will stick. Absolutely. And I think we'll have learned a lot through being forced to innovate in a very short space of time. You know, some of those things will be very positive. Other things, you know, I think we're just having to put up with before we decide we'd like to go back to what we were doing before. Yeah. So I've certainly decided that working from home is not what it's cracked up to be.
Surrounded by girls. Sounds like
Yeah. Yes. Well, actually seeing my 3 daughters and my wife more has been great, but you know, the sitting in front of Zoom all day every day is not the.
Good on the golf, so hopefully you can.
Yeah, I booked a tea time for Saturday. There was one left. Yeah.
Excellent. Oh, enjoy it, and thank you both so much, and thank you everyone for joining. We will be sending out a follow-up email after, so anyone who couldn't attend to the full thing tonight, there'll be a link that you can click through afterwards. So have a good evening, stay safe, and speak soon.
Thanks everyone.
Thanks, Mindy. Thanks, John.
Thanks, Duncan.